Hey, how you guys doing? Welcome back to another episode of Soulja Talk the podcast. I'm your host, Staff Sergeant McPherson, and on this show we discuss military topics with current and prior service members. Today I have Sergeant Holman with me. How you doing, Sergeant?
I'm doing good, pretty good, Sergeant McPherson.
Sergeant, kind of go ahead and kind of introduce yourself to the people.
Okay, so hi, my name is Sergeant Holman. I am a 68 Whiskey healthcare specialist / combat medic. I've been in for a little over 9 years now. I'm a certified paramedic and have deployed to austere environments, provided tactical medical care, and just general EMS services also in the States.
So you said you provided tactical care in theater.
I did, yes.
Okay, so I'm talking about real life stuff, like, or these y'all just.
No, definitely use real life stuff. Usually it was just the Afghan National Army guys that would get brought to us, and we'd kind of help out their medics, their doctors, kind of give them a little bit more knowledge than what they're used to having.
So you helped out what other medics?
Well, at that time it was just me, but the Afghan Army, they had their own medics embedded with them, so they would render initial care, and then they would get brought to us at the airfield, and we would render aid there also.
Okay, so you came in. That was your 6 to 8 whiskey has always been your MOS.
Yep, that's correct, Sergeant.
Cause I know it's different. It's different 6 to 8 series. So are you familiar with like the different 6 to 8 series?
I'm familiar with some of them, just not a whole ton of them. I know that the 68 Alphas, they do the medical equipment repair. I think it's 68 Papas are either X-ray technicians or behavioral health technicians, stuff like that.
So that's 6 to 8 series behavioral health.
Yes.
Okay.
Yep. So the 68 series just covers everything medical.
Mm-hmm. Because I know most of the 6 to 8 series, you have the special operations combat medics,
Mm-hmm.
you have the practical nurses,
Mm-hmm.
you have the ear, nose, and throat specialists,
Mm-hmm.
the flight medics, and then the combat medics.
Correct.
Yeah, so that's most of the 6 to 8 series. So what made you want to be a combat medic?
Honestly, when I went to the recruiter the first time, I told them that I wanted to do something medical. And then they said with my scores, it's like literally you can do just about anything. Jobs we have available are either a 68 Alpha, which is that medical equipment repair specialist, or the 68 Whiskey. And I was like, well, I don't want to be stuck in a hospital all day. So let's go with the 68 Whiskey. And that's how I kind of made that choice.
Okay, so it is a difference to where you guys work at, because I know I see some people work in the hospital,
Mm-hmm.
and where other places like you might find 6 to 8 medics other than the hospital.
Yeah, for the medics, for sure, you can be attached literally anywhere there's Army personnel. So they have clinics in the Pentagon that you can go work. Probably get attached to the White House. You can do infantry companies, artillery companies, MP battalions, anywhere that you'll find Army personnel. There's going to be an Army medic there.
Okay, so like where did you guys go to basic training at?
Basic training for us is anywhere that basic training happens. I went to Fort Jackson. And then for our AIT, though, we go to Fort Sam Houston in San Antonio. And for us, it was about 16 weeks of training. So the first 8 weeks was just our regular National Registry EMT, Emergency Medical Technician. And then the last 8 weeks were us actually learning the 68 whiskey skills that aren't taught to us during EMT.
Do you kind of remember what kind of the stuff that you guys covered in AIT?
Yeah. Well, for those first 8 weeks, it was definitely a lot of, this is how you do an initial assessment of your patient, how to recognize signs and symptoms of other kinds of injuries, what you should be looking for, how to recognize any kind of distress that your patient might be in. And then also, the most important things, oxygen and diesel as an EMT. That's really all you can do. So get taught that a lot. Just drive really fast and give them oxygen.
Okay.
But then once you become a whiskey, going through that second phase, that's where you learn all of your medications, those surgical interventions that you get trained to do, IV access, stuff like that. And then also your combat casualty assessment.
Okay, sorry. So as far as the EMT skills, so I know it's different type of skills that you guys learn. The EMT skills do they cover like certain things or what? Like I'm trying to figure out, like, does it cover like, is it like certain parts of the body or anything specific?
Honestly, it just depends on what week of school you're in. So a lot of times they start from the head and make their way down, and then in the later weeks they kind of put everything together, so you're not getting flooded with just literally everything.
Okay, so the EMT skills, what does that? Do you have EMT skills at all parts of the body, or?
Yes. So basic stuff you could do. There's splinting, suctioning. So usually out of the mouth or nose is where a lot of suctioning takes place, because that's where people like to breathe from. So you got to make sure that's nice and clear for that air to move in and out.
Okay, sorry. Today, kind of wanted to cover some of the EMT skills. So far as today, I just wanted to cover. I wanted you to kind of inform the soldiers who don't know about the different type of EMT skills.
Okay.
Far as the how you say that?
Yeah, oropharyngeal suctioning.
Okay, the oropharyngeal suctioning. Okay. So kind of give a brief explanation on what is that.
Okay, so oropharyngeal, that just means oro or oral, so suctioning of the mouth. So anywhere from the teeth to the back of the throat is encompassed in that whole section.
Okay, what would be a situation to where you would have to do an oropharyngeal suctioning?
Yeah. So a lot of times with medications that get administered to some people, they might have a bad reaction and it might cause nausea and they might throw up. And a lot of times as a patient, either on a litter or an EMT stretcher, you're strapped down so you're not moving anywhere. And if you throw up, we want to make sure that you're not going to inhale that back in. So once we see that happening, we're going to try to turn your head to the side, let it kind of move itself out. And then once that's done, we'll have our suctioning device and we'll kind of clear out any kind of extra stuff that's in there. And just to make sure your airway's nice and clear.
Okay, but because it says here that the oropharyngeal suctioning is a procedure used to remove secretions from the oral cavity and pharynx.
Yeah, pharynx. So the back of the throat above the larynx or your voice box.
Okay. It says secretions can block the trachea and obstruct the normal airflow, which can lead to an insufficient oxygen supply. Normally, clients cough to remove these secretions, but some individuals are too weak or cannot cough, so these clients require suctioning to clear the airway. So would that be like if something is stuck in your throat?
Yeah, for sure. And then also, like any kind of diseases, sometimes you might have that excess buildup of spit a lot of times. So normal people, either they spit it out or just are weird and swallow it. But again, like you said, for anyone too weak to do that, that's what that suctioning is for. And then also any kind of injuries that might be in the mouth that can be used to suction out the blood that's back in there too.
Okay. So it says the indications for oropharyngeal suctioning, the common signs and symptoms that suggest a client may require that type of suction are difficulty coughing up secretions and swallowing, decreased consciousness, visible secretions that obstruct the airflow. So visible secretions, what would that be like? Visible secretions, like something actually, like somebody got stabbed in the neck or something like that?
That, and then also if they're not breathing, a lot of times one of the most important things we have to do is do a visual examination. So we try to open the mouth as much as we can and then look inside, see what's going on in there. And if we see anything kind of hanging out in the back of the throat, it looks like just a little excess fluid back there, any kind, whether it's blood, vomit, saliva, stuff like that, or pus, maybe even if they had a really bad infection in their mouth and it decided to rupture or something and fill up the back of their throat. So we can see that and like, oh, okay, need to get that going, clear that out of there.
Okay, it says the vomitus in the mouth or noisy breath sounds. So what noisy breath sounds, that would be what?
Snoring is definitely a noisy breath sound. Gurgling, so it'll just be that normal like movie gurgling sound. Someone gets shot in the neck, like oh god. So yeah, that's definitely what you're listening for. Or also if they're kind of unconscious, you're not really breathing a whole lot, or you might see some stuff leaking out of the mouth too, so that could kind of clue you in.
Okay. So it says the procedure is also used in individuals who have had oral surgeries, mouth trauma, or cerebrovascular injuries.
Mm-hmm.
You know what that is?
Cerebrovascular?
Yes, cerebrovascular.
Yeah, so that's any kind of damage to the brain and all the blood vessels up there. So suction can be used for those. It'll be looks like just one of those little bulb suction devices, a turkey baster, I guess. Just that little bulb at the end. They squeeze it, and then there's a tube that goes into the head where that injury was, and it kind of hooks in, and then it uses that kind of, as it re-expands, it pulls out any kind of excess fluid out of the head.
Okay. He says, like a stroke that results in drooling and impaired swallowing.
Mm-hmm.
Finally, the oropharyngeal suctioning is used to provide oral hygiene and prevent infection in individuals that have impaired swallowing or artificial airway. So artificial airway, so artificial airway,
Mm-hmm.
do they replace like people like actual throat? Like
They can, but in this case, it's for usually during a surgery or after a surgery. They've been intubated, so an airway tube, probably about 12 inches long, is inserted through the air into their breathing tube, and it allows them to actually move air in and out. Or they're hooked up to a ventilator, and it's the machine that actually breathes for them. So with the suction, though, since they can't really swallow with that in the way, and they've been usually sedated, knocked out, paralyzed, good stuff like that, nurses will go in, do the suctioning around, usually probably a couple times a day, just to make sure nothing hangs out in there. Because if it does hang out, it can cause bacteria to grow and just can cause all kinds of infections. So it's all about keeping your patient healthy, keeping them nice and clean, so that when they leave the hospital, they're in a better condition than when they got there.
Okay, so it says right here, part is the oropharyngeal suctioning. It also has a yanker suction device.
Mm-hmm.
You familiar with that?
I am. Yep, it's just a rigid suction tip. So that's the most common one that gets used in hospitals. It's pretty straight, and then at the end it'll curve down a little bit, so it'll kind of match the curve at the back of the throat. And it's pretty open. It just hooks up to a normal flexible tube, then that connects to the suction device, and that's usually, you turn off the suction, you want to insert it, and usually you measure it from the corner of the mouth. A bug.
No, it was a spider.
Fine. But usually when you're measuring, you want to go from the tip of the mouth to the corner of the jaw, because that's usually about where that gag reflex is going to kick in the back of the throat. So then when you have that, you kind of measure off with your hand, and then you insert it up to that measurement point, turn the suction back on, and then you kind of sweep back and forth, making your way out, vacuuming out the mouth with that little rigid suction device.
Okay, because it said the suction catheter used for oropharyngeal suction is a rigid, bent, and plastic catheter called the yanker suction catheter or yanker tip. A yanker suction catheter is transparent, which lets you see the secretions and fluids being suctioned out. The standard type of yanker catheter has a bulb tip with one large and several smaller openings. The bulb tip prevents trauma to the oral cavity, while smaller openings provide suction even if large openings is blocked.
Mm-hmm.
So it says, you know what type of supplies you would need for those type of procedures, Sergeant?
For those procedures, generally, as a medic in a medical platoon or as a line medic with an infantry company, something like that, you'll have a suction kit that goes with you, and it'll have the yank hour tip, a couple of the flexible tubing for you to hook it up to your suction device, and then it'll either be a manual suction device or an actual battery-powered suction device, and it'll have the clear containers that'll kind of let you see how much and what you're suctioning out.
Okay, because as far as like when you get ready to do the procedure, it says you have to have clean gloves, mask and goggles or a face shield, bath towels, cloth or disposable paper drape, disposable cup or wash basin, tap water or normal saline, the suction device and connecting tubing, an oral airway, and washcloth. So for the procedure, it says the client should be in a semi-Fowler or sitting position with a bath towel cloth or paper draped over their chest. Perform hand hygiene and apply clean gloves. Use a face shield or mask because suction can cause splashing, like splashing of the blood. I guess blood.
Yep, just any kind of fluid that you're suctioning out has a chance to splash out. So you just want to protect yourself as much as possible.
Says fill the cup or wash basin with water or normal saline. Insert the catheter and run it along the gum line to the pharynx where the secretions are suctioned out. Rinse the catheter by placing it in the cup or wash basin because this prevents the catheter and connecting tubing before becoming clogged with secretions. Once done, remove the bath towel cloth or disposable drape, reposition your client, and then clean up the supplies, remove the gloves and face shield, and perform hand hygiene. So that's the procedure, and I guess using the yanker.
Correct.
Okay. So Sergeant Holman had basically gave you guys some clarification on the oropharyngeal suctioning. So that's basically that procedure and stuff that what you would do if in different circumstances as far as like what might happen if somebody, I guess, have a clogged what I'm looking for.
Airway, throat.
Yeah, airway, clogged airway. That's what I'm looking for. So the next thing I want to talk about, Sergeant Holman, was the tracheostomy.
Okay.
Can you give the people like a brief overview of the what the tracheostomy is?
Okay. So yeah, for tracheostomy, it's also called a surgical cricothyroidotomy, or it can be called that. But usually, the tracheostomy is an airway or hole that goes right here on the throat, and it's beneath the vocal cords. There's some cartilage here that protects that. It'll go in between in one of those soft spots in the trachea, and it'll go in, and it allows for access for either they have possibly some kind of neurological injury that prevented their airway from actually working properly, or in a trauma situation, their upper airway, their oropharynx, was damaged too much where they can't breathe on their own. So that is used to kind of bypass all those injuries and allow that airway to get in place so they can still breathe.
Okay, sorry. So as far as the tracheostomy, it says tracheostomy is also known as the tracheotomy, a small surgical opening that is made through the front of the neck into the windpipe or trachea. A curved plastic tube known as the tracheostomy tube is placed through the hole, allowing air to flow in and out of the windpipe. The tube does not extend into the lungs. It says the tube allows the person to breathe through the throat, bypassing their upper airway, including their nose and mouth. A tracheostomy may be temporary or permanent, done as an emergency or done as planned procedure. So I guess someone can have surgery and have a tracheostomy actually a part of their like daily lifestyle.
Yep, correct.
And you know what would that? Why would that be? Like, why would they need that?
Like I said, for some people, I know I have a friend. His daughter, she has a neurologic disorder, and she's wheelchair bound, and that's her primary breathing source is the tracheotomy, and she has her tube in there. It's just part of her daily life, their daily life. It's cleaning, making sure all her air is moving in and out, all that good stuff. And then also, sometimes might have some kind of mouth surgery or just a lot of damage in the back of the throat where your airway's not going to work properly. So again, they have to bypass all that to allow you to breathe.
Okay, then it says, why would a tracheostomy be performed? It's performed when an adult or a child has a condition that makes normal breathing difficult or impossible. People have tracheostomies for different reasons, and some of those different reasons are, did you just speak about neurological conditions?
Yes.
Neurological conditions such as a stroke or tumors, severe injuries to the head and neck, spinal injuries, burns, severe pneumonia, acquired and congenital subglottic stenosis, a condition where the windpipe is narrow, severe allergic reactions, head and neck cancer, radiation therapy to the head and neck, and severe lung disease. So, Sarah Holman, do you know how to perform a tracheostomy?
I do.
Can you explain to the people on how, what would you do? And I would say, do y'all have them in theater? Like far as if okay,
Yep,
so
it's one of those theater skills that we've trained on.
yeah, sorry. So in a field environment or in a deployed environment, how would you basically perform a tracheostomy under those type of circumstances?
Okay. So for those, the nice thing is everybody loves their combat medics. So a lot of medical supply companies have built these tracheostomy kits, and they come with the airway tube, scalpel, alcohol swabs, tie down, all that good stuff, all the supplies that you'd need to perform that. They come in, it's a little package, ready to go. So all you got to do is when you need to do this, just grab that and then get going. So, as always, in the field, though, not really going to have a chance to really wash your hands. Keep everything clean as much as possible. Technically, it is a sterile procedure because you are going inside the body. So you want to, again, just try to keep it as clean as possible. So at this point, definitely should try to put on some gloves if you can. And then first step after that is you want to identify your landmark. So again, like I said, if you find your Adam's apple and then slide a little bit down, you're going to feel a little divot right underneath it. You're going to feel your Adam's apple down, and there's going to be another smaller hard spot underneath that, and it's going to be right in between those two. That's your landmark right there. So positioning, though, definitely want to try to get their head back as far as possible so it gives you a good amount of working space, because if not, they're sitting like this, you got maybe 1.5 inches of space. So if you can get their head back, it'll pull that trachea up out of the chest a little bit, and they'll kind of help you out. And then once you do that, you're going to grab it, not too tight. You want to still make sure they can kind of breathe, because at this point, they might be breathing on their own a little bit, but they're starting to not breathe so well. So this is when you're having to make those critical decision-making stuff, like, okay, he's not breathing well, I need to do this. So again, you're just going to grab it, hold it still, you take your alcohol swab, clean it off as much as you can, and then you have your scalpel. You're going to go vertically, so down the throat. You don't want to go side to side. That's where your veins and arteries kind of hang out. So if you go side to side, that's a chance that you just killed your patient. So you're going to go up and down vertical, make a vertical incision. It doesn't have to be super, super big, so about 1 inch or 1.5 inches. Once you do that, you're going to try to go through, find that membrane that you need to poke through to get into their trachea. You're going to take your scalpel, you're going to puncture through that. Then you have what's called a trach hook or a tracheotomy hook. And literally, it's just a sharp hook you put inside the hole. It grabs onto the trachea. And then you pull that, and you're holding that still that way. So as you insert the tube, it's not going to slide back inside the body. And then once you have that secured with that hook, take your tracheostomy tube, insert it down. Make sure you're going down towards the lungs, not up towards the head. It's not going to do them any good. Once that's in, there's a little air balloon at the end of the tube that'll fill up and hold it in place, and leaving the end open for that air to move in and out. Once that's done, you have your BVM or bag valve mask, which you hook up to the end, and it's literally that. It's got a bag that you squeeze, and it pushes air into their lungs. And what you're looking for is when you do that initial squeeze, you want both sides of the chest to have that nice equal rise and fall. Because if you don't, if only the right side raises up, that means that tube went in too deep, and you're just inside the right lung. So if that happens, back it out a little bit, and then test it again, and then hopefully you should see that nice equal rise and fall of the chest. Once that's done, just secure it down, either some tape, some gauze, whatever you have to just hold that down in place, because you don't want that slipping out. That's their airway. That's how they're breathing, so you want to make sure that's nice and protected.
Okay, sorry. So, how long you think that process will take in a deployed environment where like you getting shot at?
I've done it in like almost a little over 2 minutes.
It's that quick. Where when you under pressure.
Uh, Worst part is just the shaking when you're getting ready to cut into them because you're like, man, I know this is gonna hurt. It's like I'm a medic. I'm not supposed to hurt my patient, but at that point, it's one of those I gotta hurt you to help you.
Okay, so sorry. What happens after a tracheostomy? So, do they have any side effects or anything?
Usually, if they heal properly, there might just be a little bit of scarring. Usually, that can get sealed back up pretty well. That membrane will heal up. But again, sometimes they might be stuck with that tracheostomy tube for a while as they go through their recovery process, depending on how severe their injuries were.
Okay, because it says what happened. It said after a tracheostomy, nurses, psychotherapists, dietitians, and speech therapists work together to help care for people who have had a tracheostomy. So after surgery, nurses may need to suction mucus out of the tube. Psychotherapists can help the lungs clear of mucus, and speech therapists can help with swallowing and speaking. Tracheostomy tube needs to be changed regularly. People who go home with the tracheostomy might be given instructions on how to care for it and how to change the tube. Sometimes they need to come back to the hospital to have the tube changed. And it says some of the risk and side effects of a tracheostomy is some of the risks are bleeding and damage to the throat, blockage of the tube with secretions, which can be breathed into the lungs, causing pneumonia, infection, tube displacement, scar formation, like you just said. So, it says, do you know any alternatives to a tracheostomy? Like, if somebody don't want to get that done, like, are there any alternatives?
Unfortunately, not really. Usually with tracheostomies, at that point, they've tried a bunch of other stuff already, and that's kind of one of those last measures since you're actually having to cut into the body to insert that airway.
Okay. So sorry. So now, sorry, hope you basically just explained the basics of a tracheostomy. So is anything you feel like you didn't leave out for the as far as the tracheostomy? Sorry, because just want to make sure if any soldiers out there who might be still in AIT or some of the stuff that they might don't cover, some of the stuff that you learned here when you got to what's the difference on the training as far as when you actually get to your duty station and what type of training do you guys do to stay stay on point as far as the stuff that you know and kind of taking it to the next level on stuff that you need to know. You know what I'm saying?
Yeah. So usually medics we go through every year. It's called Table 8 training. So it's all of our medical skills, gets you 48 critical education units. Because with the EMT certification, it is a civilian certification, and we have to maintain that as a whiskey. So getting those hours helps us progress towards actually keeping that certification. But they go over everything. They break it down Barney style. They talk about everything, just basic EMS skills. Again, just teaching you everything all over again, just to make sure it stays fresh in your mind. And then also any kind of updates that might come out from